Hi guys, welcome back. So for today's video, we're going to discuss the techniques of examination for the cardiovascular system. So first of all, let me apologize because there's going to be a loud noise. They're doing some building works next door, so that's going to be annoying. But anyway, let's get on with the topic for today. So firstly, when a patient comes to see us, we need to conduct a general inspection of the patient. So this would give us clues regarding their cardiovascular health. So we just look at things like their skin color. Are they pale? Are they cyanotic? Is the patient obese? If their legs are exposed, can we see any signs of edema? Do they look like they're in pain? Like if they're clutching their chest, then that's indicative that they have chest pain. Just general things like this is the first step that we need to do when we're assessing the patient. And then the second step is to measure their blood pressure and measure their heart rate. When we're taking the patient's blood pressure, we need to conduct this in a quiet room with very minimal distractions and noise. And then we let the patient rest for at least 5 minutes because they might have just run, to the consultation room. You never know. So we need to let them rest for 5 minutes. And then we need to select the correct size cuff for the sphygmomanometer. So, there's adult cuffs, there are pediatric ones. So you need to select the correct size. Then we need to position the patient's unclothed arm around heart level. So that's around the fourth intercostal space. If you lift it higher up, the blood pressure will be lower. If you let it fall below chest level, then the blood pressure that will be recorded will be higher. So it can't be like this. It has to be unclothed. And you make sure that the diaphragm of the cuff is centered over the brachial artery. What you do is you inflate the cuff around about 30 millimeters of mercury from the point where the brachial pulse disappears, and then you deflate it slowly. And you listen for the sounds, the carotid sounds. So the first sound that you hear corresponds to the systolic blood pressure, and the last carotid sound that you hear corresponds to diastolic blood pressure. When measuring the heart rate, we can palpate the radial pulse, or we can auscultate the apical pulse from the PMI, the apex of the heart, using our stethoscope. So the third thing that we assess is the JVP. So the JVP is usually measured at a vertical distance from the sternal angle, so the angle of Louis. So that's like the bony ridge where the manubrium joins with the sternum. So if the JVP is greater than 3 cm above the sternal angle, or greater than 8 cm above the right atrium, then this is considered elevated or abnormal. Now let's describe the steps we need to take to measure the patient's JVP. So first of all, we need to ask the patient to lie supine, and we have to make sure that they are comfortable. We raise the head of the bed to about 30 degrees. And then we ask the patient to turn their head away from the side that we are inspecting. So if we're inspecting the right side, we ask them to turn to the left side and vice versa. And we need to examine both sides of the neck. Since the internal jugular vein lies beneath the sternocleidomastoid, it's actually quite difficult to find. So what we can do is we can use tangential lighting. So what this basically means is we can use a pen light to shine. We have to shine like a pen light diagonally. Is that diagonally? Horizontally to the patient's neck to identify the jugular vein pulsations. So firstly, what we need to find is the external jugular vein. And the external jugular vein runs lateral to the internal jugular vein. So we need to find the external jugular vein from both sides. And then we find the internal jugular vein pulsations. It might be necessary for us to readjust the angle of the head of the bed just to help us see the oscillation point of the JVP a lot better. For example, this can happen if the patient is hypovolemic or if the patient is septic. We would expect the JVP to be low, and therefore we need to readjust the bed. We need to lower it, sometimes even to 0 degrees, just to help us visualize the point of oscillation the best. And the inverse is true. So if our patient is hypervolemic, the JVP would be high, and therefore we might have to adjust the angle of the head of the bed up to 60 degrees or sometimes even 90 degrees just to let us visualize that point of oscillation better. So once you've identified the highest point of oscillation, you need to extend a rectangular object or any object with a straight edge, like a tongue depressor, for example. That's actually quite a good one to use here. From that point, and then you need to place a ruler vertically from the sternal angle, and then these 2 points should meet, and then you need to measure the JVP. So I'm gonna try to show it to you guys, but obviously it's not gonna be accurate because I can't really do this to myself. So just imagine I'm lying supine, 30 degrees, whatever. And then I locate the highest point of oscillation of the JVP, and I put a straight edge horizontally from that point, and then I put a ruler vertically from the angle of Louis, and they should make like an angle. And can you see that where they join? That vertical distance you need to measure. So it's abnormal if that is greater than 3 centimeters. So just to summarize, what we do is we measure the vertical distance from the sternal angle where that horizontal object crosses the ruler. And this measurement should be less than 3 centimeters. And to this number, we could add 5 centimeters to measure the distance from the right atrium. And those two numbers combined gives you the JVP. When we're measuring the JVP, we need to be really cautious not to look at the carotid pulsations. So there are a few ways you can distinguish the point of oscillation of the JVP from the carotid pulse. So firstly, the carotid pulse will have a palpable pulse. You could actually feel the pulsations. But JVP, it's rarely palpable. Actually, you won't be able to feel it. And the JVP will have 2 pulsations per heartbeat, whereas the carotid would obviously just have 1 pulsation per heartbeat. Also, the JVP, the position of the highest point of oscillation would change depending on the patient's position. So if you place the patient more upright, the point of oscillation will drop. The carotid pulse, on the other hand, is going to be unaffected by the change in position. With the JVP, the height of pulsations will fall with inspiration, whereas again, the height of pulsations will be unaffected by respiration if it's the carotid pulse. And finally, with the JVP, you would see a transient increase in JVP if you press on the liver, which is on the right upper quadrant, due to the hepatojugular reflex. So the elevated JVP is correlated with both acute and chronic heart failure. This can also be seen in tricuspid stenosis, chronic pulmonary hypertension, superior vena cava obstruction, cardiac tamponade, and constrictive pericarditis. The fourth thing that we need to assess is the carotid pulse. So we need to assess the upstroke, the amplitude, the contour, the presence or absence of thrills or bruit. So the carotid pulse may actually be visible sometimes, medial to the sternocleidomastoid. What we need to do is we need to palpate this using our middle finger and our index finger, but we don't palpate both of the carotid arteries at the same time because this will lead to the decreased blood flow in the brain and may induce syncope. So we need to assess specific characteristics of the carotid pulse, starting with the amplitude. So the amplitude is, it actually correlates well with the pulse pressure. So if the amplitude is weak, then this might be indicative of cardiogenic shock. If the pulse is bounding, then this might suggest aortic regurgitation. And then we need to assess the contour. So the contour refers to the speed of the upstroke, the duration of the summit, and the speed of the downstroke. So normally, the upstroke is brisk and the summit is smooth and rounded, and the downstroke is less abrupt than that of the upstroke. When we're assessing the carotid pulse, we might feel variations in the amplitude. So if we feel variations in the amplitude beat to beat, then this is pulsus alternans. If we feel varying amplitudes with respiration, then this is a paradoxical pulse. Pulsus alternans happen when the rhythm of the beat remains regular, but the force of the pulse varies or alternates between weak and strong, with the alternating weak and strong ventricular contractions. This is usually indicative of severe left ventricular dysfunction. A paradoxical pulse, or pulsus paradoxus, happens when the amplitude of the pulse varies with respiration. So usually the systolic blood pressure decreases during inspiration due to the decrease in intrathoracic pressure. But usually the magnitude is so small, like less than 10 millimeters of mercury, and is not appreciated by palpation. A more marked or greater decrease in arterial blood pressure during inspiration, like greater than 10 millimeters of mercury, is called pulsus paradoxus. So this can be appreciated by palpation and has to be double checked or has to be confirmed using a sphygmomanometer. If we identify pulsus paradoxus, we need to immediately suspect cardiac tamponade. Pulsus paradoxus is also present in other conditions like constrictive pericarditis, PEs, and acute asthma. So after palpating the carotid pulse, we need to auscultate the carotids. So what we can do is we can ask the patient to stop breathing for a few seconds and listen for any bruits in the carotids using the diaphragm of our stethoscope. So this bit of the stethoscope. If we can't assess the carotids for whatever reason, so for example, if there's carotid obstruction or there's kinking or thrills, then we can use the brachial artery instead. So we can assess the brachial pulse. We follow the same techniques. We assess for the same things. We assess for the amplitude and the contour. So what you need to do is you need to expose the brachial artery. The arm must be extended with palm facing up, and you use your index and middle finger to palpate the brachial pulse. So just a quick recap so far. We've done general inspection, we've taken the blood pressure measurement and the heart rate, we've assessed the JVP, we've assessed the carotid or the brachial pulse, whichever one we can assess. And then after that, we move on to the heart. Finally, my favorite. So for the examination of the heart, we follow the same sequence as that of the other organ systems. We do inspection, palpation. We don't really do percussion, so we skip that one, and then we do auscultation. Let's start with inspection. So our patient is lying supine with head elevated like 30 degrees, and we need to inspect the chest so we can reveal the location of the apical impulse. Sometimes this is visible, sometimes it's not, but that's fine. We need to look for any asymmetries in the chest, any deformities, any scars, any lesions, any ecchymosis, anything we could note. We just look at the chest and note anything that seems abnormal. Firstly, we can palpate for heaves and lifts. So these are sustained impulses that rhythmically lift your fingers. They are usually generated by enlarged ventricles or even atria. And what we need to do is very simple. We just need to put our hand flat on the patient's chest and feel for these heaves or thrills. It's just like that. Oh, like this, okay? I can't do it properly because I'm doing it to myself. But you just lay your hand flat and you just feel for these sensations. Sorry guys, just so you know, you need to lay your hand flat directly on the person's bare chest. Obviously, I can't take my clothes off, but that's the idea, okay? So you need to expose their chest and you need to palpate directly the patient's bare chest. So the next thing that we can palpate for are thrills. So thrills are just palpable murmurs. So these are usually generated by turbulent blood flow through a valve or a vessel. It's so marked that it produces vibrations that we can feel. So if we feel thrills in any areas, we need to auscultate those areas as well to listen for the murmurs. So the next thing that we palpate for is the point of maximal impulse, or the PMI. So we specifically assess for 4 different things. So we assess the location, we assess the amplitude, we assess the diameter, and we assess the duration. So in terms of location, usually the PMI is located at the apex of the heart. So fifth intercostal space, left side mid-clavicular, but there are special cases where we would find the PMI in a slightly different place. One of these special cases, just to give you guys an example, is dextrocardia. So dextrocardia is a rare congenital transposition of the heart, meaning that the heart is located on the right side of the chest cavity and therefore generating right apical impulse. Also, in patients with situs inversus, which is another condition where the heart and other organs like the stomach and the spleen are all on the other side, or all on the right side, we can feel the PMI on the right side of the chest. Also, a more common example is during pregnancy. So because the uterus pushes the diaphragm upwards, that might push the apical impulse slightly upwards as well. Also, the PMI might be displaced laterally towards the axillary line if there is ventricular dilatation in the case of heart failure, for example. Also, if there are any thoracic deformities or any conditions that causes a mediastinal shift. So after assessing the location, we need to assess the diameter of the PMI. So in a supine patient, the PMI can be as big as 1 to 2.5 centimeters in diameter. So if it's more than 3 cm, then this might be indicative of left ventricular hypertrophy. So after assessing the diameter, we can assess the amplitude of the PMI. So in young adults, there might be a hyperkinetic high amplitude. And this can also be present if the patient is like hyperthyroid or if there's any pressure overload. And as a side note, if you can't palpate the patient's PMI when they're in the supine position, you could ask them to roll into the left lateral decubitus position. And what this does, it brings the apex of the heart closer to the chest wall, so it might be easier for you to hear the apical impulse when they're in this position. So after palpating the PMI, we can then move on to palpating the right ventricular area. So the right ventricular area is between the third, fourth, and fifth intercostal space, left side parasternal border. So this might be tricky in patients with a large AP diameter, so if their chest is really deep. So we can see this in patients with obstructive pulmonary diseases, or if their lungs are hyperinflated in the case of like COPD. So what we can do is we can ask the patient to inhale and then breathe out and hold it there. And we can palpate for the right ventricle at the epigastric region or the subxiphoid area. Finally, we palpate the aortic and pulmonic areas for any pulsations or any transmitted heart sounds. Just to summarize palpation really quickly, so we need to palpate for any heaves and lifts, we need to palpate for any thrills, we need to palpate for the PMI, we need to assess the PMI's location, amplitude, duration, and diameter, and then we palpate for the right ventricular area, and then we palpate for the pulmonic and aortic valve areas. After palpation, usually we do percussion, but in this case, we don't really percuss the heart because palpation is used to estimate cardiac size instead of percussion. And percussion has very limited correlation with the borders of the heart. And the last part for examination is auscultation. So for auscultation, we use our friend, our stethoscope. So we need to be really familiar with the stethoscope. So this side is the diaphragm and this side is the bell. The diaphragm is better for picking up high-pitched sounds. For example, the sounds of S1, S2, or aortic and mitral regurg, or pericardial friction rubs. Whereas the bell of the stethoscope is better for picking up low pitch sounds. So that's like the sound of S3, S4, mitral stenosis. So in terms of patterns of auscultation, you could really do it either way. You could start from the apex and move up to the base of the heart, or you could do it the other way around. You could start from the base and move down to the apex of the heart. So when we're auscultating the chest and listening to these heart sounds, we need to identify where we are in the cardiac cycle. So we need to identify systole and diastole, and we need to distinguish in which phase we're in when we're listening to the heart sound. So we do this by simultaneously auscultating the chest with their stethoscope and feeling the right carotid artery. So as we're listening to the chest, we palpate the right carotid artery, and we know that S1 falls just before the carotid upstroke, and S2 happens just after the carotid upstroke. Also, when we're auscultating the base of the heart, S2 might be louder than S1, and we may hear the splitting of S2. And the opposite is true. So at the apex, the S1 sound is louder than the S2 sound. And finally, we can auscultate for the murmurs. So there are different information that we can gather to help us identify which type of murmur we're hearing. So for instance, we could see the timing of the murmur. Does it happen in systole or does it happen in diastole? So if it happens between systole, which is between S2 and S1, then does this murmur happen early in systole? So if it does, then that might be aortic stenosis, pulmonic stenosis, or hypertrophic obstructive cardiomyopathy. If it happens mid-systole, that can be a mitral valve prolapse. If it happens throughout systole, then it's a holosystolic murmur, so this can be mitral regurg or tricuspid regurg. If the murmur happens during diastole, so between S1 and S2, then this can be aortic regurgitation, pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. If this murmur happens throughout the whole of the cardiac cycle, so from S1 to S2 to the next S1, then this can be, if it's a continuous murmur, then this can be a PDA or patent ductus arteriosus. Secondly, we can assess the location of the murmur. So where is this murmur heard the loudest? So for instance, this murmur is heard the loudest at the fifth intercostal space, mid-clavicular left-hand side. So at the mitral region. So this might suggest problems with the mitral valve. So we might have mitral stenosis or mitral regurg. Also, does it radiate anywhere? If it radiates up in the axilla, then this can be mitral regurg or mitral valve prolapse. The third thing we can ask ourselves is, what is the shape of this murmur? Is it a murmur that grows louder? So is it a crescendo murmur? Is it a murmur that grows softer over time, or a decrescendo murmur? Is it a murmur that intensifies at the beginning and then falls down in intensity or decreases in intensity? Then this is a crescendo-decrescendo murmur. Or is it a murmur that has the same intensity throughout? For example, like a holosystolic murmur or a plateau murmur. Also, the pitch and the quality of the murmur can help us identify the type of murmur. So for instance, is this a blowing type of murmur? So blowing type of murmurs or musical sounding murmurs are usually regurg murmurs, regurgitation murmurs, like in the case of mitral regurg and tricuspid regurg. Is this a machine-like murmur? So that's in the case of a PDA, a patent ductus arteriosus. Or is this a rumbling type of murmur, like in the case of mitral stenosis and tricuspid stenosis? So in mitral or tricuspid stenosis, there's an opening snap followed by a diastolic decrescendo rumble. So once we've identified the murmur that we're hearing, we need to just categorize it based on intensity. So we need to grade the murmur. I've spoke about this in my previous videos, so please watch that. Basically, we grade it from 1 to 6, and anything above 3 is considered pathological in most cases. So for the last part of this video, I want to talk to you guys about the certain maneuvers we can do to accentuate or to intensify certain murmurs. I've already spoken about this in my last video, but I think I mentioned 4 different maneuvers, but there's a lot more. So just for completion, I want to go over all of the possible, well, not all of the possible, but like some of the other more common maneuvers that we can do to intensify certain murmurs. Just a quick recap from the last video. We spoke about inspiration, expiration. I think we spoke about rolling the patient in the left lateral decubitus position, as well as getting the patient to lean forwards. So deep inspiration, intensifies all right-sided murmurs. Okay, I'm not going to go over the explanation because I've already done that in the previous video, but deep inspiration intensifies all right-sided murmurs. Expiration, on the other hand, intensifies left-sided murmurs. Expiration intensifies left-sided murmurs, all left-sided murmurs. And then leaning forwards, what that does is it brings the aortic valve area closer to the chest wall. So that intensify or that accentuates the aortic murmurs that we can hear, like for example, aortic regurgitation. And then rolling the patient onto the left lateral decubitus position brings the mitral valve area, so the apex of the heart, closer to the chest wall. So this enables us to hear mitral valve murmurs better, including mitral stenosis. I want to discuss 3 more maneuvers. So isometric hand grip, Valsalva maneuver, as well as squatting. So let's start with Valsalva maneuver. A Valsalva maneuver is a forceful exhalation against a closed glottis after a full inspiration. So what this does, so it's like taking a deep breath in and then forcefully trying to exhale with your closed mouth and closed glottis, so air can't really escape. So this increases intrathoracic pressure, and what that does, it decreases preload, it decreases stroke volume, and therefore it decreases the intensity of all murmurs, except hypertrophic obstructive cardiomyopathy, because that increases with Valsalva, and with mitral valve prolapse. What Valsalva does, it makes the ejection click happen earlier in systole, and it lengthens the duration of the regurg murmur that follows the ejection click. Squatting, on the other hand, does the complete opposite. So with squatting, what happens is that we squeeze the veins in our legs and we push blood back up to our heart. So this increases venous return, it increases preload, it increases stroke volume, and therefore it increases all murmurs, increases the intensity of all murmurs, except again for hypertrophic obstructive cardiomyopathy, because squatting decreases the intensity of hypertrophic obstructive cardiomyopathy, but increases everything else. And with mitral valve prolapse, what squatting does, it makes the ejection click occur later in systole, and it shortens the regurg murmur that follows that ejection click. So now with the isometric hand grip, what happens is when you grip your hands really tightly, you increase the systemic vascular resistance. And what that does is it increases the afterload. With the increased afterload, you decrease your stroke volume, and therefore you decrease the forward flow of blood from the left ventricle to the aorta, meaning that you will make the murmur of aortic stenosis less intense. But the opposite will be true, because when you increase the systemic vascular resistance, you increase the afterload, but at the same time you increase the aortic pressure, which means that the backward flow from the aorta to the left ventricle would increase, and therefore this would intensify the murmur of an aortic regurgitation. And the same with mitral regurg, actually. And for mitral valve prolapse, what the isometric hand grip does is it delays the ejection click later in the systole, and it decreases or it shortens the duration of the regurg murmur that happens after that ejection click.